Hello, my name is Dylan Hofmann, and this is my clinical philosophy. Specifically, what we're going to be doing today is taking a lower extremity case and applying it to the philosophy. To start, I wanted to discuss my clinical philosophy. It can be broken up into four phases: pre-injury, evaluation, treatment, and discharge. And every patient under my care will always be under one of these. To start, it's important to know that phase one, or the pre-injury, includes anybody who I may not have treated for an injury already. So anybody under my care falls into this phase one category prior to any injury that they may receive. This includes things like your pre-participation exams, pre-activity exams, any kind of baseline testing so you can have a baseline understanding in reading, and then interventions to reduce those things. So if you're noticing things that put people at a higher risk during your PPE or your baseline testing, you can intervene into those, or you can intervene into your patient's activities to make sure you're reducing risk. Phase two is after a patient receives an injury or comes in with some type of complaint, something that they're wanting help with. And this is really broken up into two major goals. It's understanding who the patient is, and then understanding what impairments, what's causing their pain, what kind of issues are going on with the patient. And so that's where you can really break down your evaluation into those. But the biggest goal of evaluation is understanding who the patient is, understanding what the patient's goals are, because they may be different than your own goals, and then working to identify pain, identify impairments, and then develop a plan with the patient, educating them along the way to treat those issues. And just a side note, it's important to understand that I have educate the patient in evaluation because I think it's important during that phase. But educate the patient is going to be something that is going to be found without all four phases. Phase three is the treatment. What we want to do is we want to take those identified pain generators or those identified impairments, and we want to specifically choose and intentionally choose interventions that are going to affect those. All right, so being specific, being intentional in what we're choosing, whether that's modalities to treat things for their pain or improve mobility, or therapeutic exercises to improve strength and function. We want to measure and determine our progress, both see how they're progressing and determine when we can progress based on outcomes, based on measurable data that we can collect. And we want to give the patient options throughout the treatment phase. At the end of the treatment phase is the discharge phase. Again, we get into this phase when we have met the goals that were decided by the patient, right? So these are not our goals, these are goals decided by the patient. We get to this phase when we start to use the outcomes, and we can look at what we see in our outcomes, what we see in the evidence, in our evidence-based practice, our patient's input, and our own experience, and we can really use that evidence-based model to guide us towards making a decision for discharge. And then it's important to know that as soon as someone is done with discharge and they're out of that phase four, they go straight back to that phase one pre-injury, right? And we continue to try and reduce the risk. So let's talk real quick about the model patient here. This is the same patient I had for previous models of my clinical philosophy. It's a patient with iliopsoas tendinosis. Body structure and some of the findings that we found: shortened left psoas, poor hip internal rotation or decreased hip internal rotation, mostly seeing that from a capsular standpoint, so some posterior tightness of the hip capsule on the left side, an anterior tilt of the pelvis, or that kind of anterior innominate. Manual muscle testing revealed some weakness of the left iliopsoas, and we're going to see some kind of more broad dynamic knee valgus in this patient as well. As far as activity is concerned, the patient does present with a quad dominant squat. They have pain with prolonged running and jumping activities. This athlete or this patient participates in basketball, is a basketball player. Specifically, he's a senior with some scholarship offers. And so those offers are really dependent on the patient's ability to play at a high level. The student athlete has a positive relationship with coaches and with the teachers as well. The patient's mother is also involved in the school, so there's not really a ton of environmental factors that may make treatment of this patient more difficult. Personal factors: patient is a minor, patient 17-year-old male, and they've been playing through this hip pain for really over a year. And it's kind of been on and off before coming under my care. Participation, again, unable to participate in practice and is getting decreased playing time in games, which can affect those scholarships that the patient is trying to get. So let's go through the philosophy and let's apply this case to that philosophy. Starting off, we're in our phase 1, we're in our pre-injury phase. This would hopefully be before the patient ever came in. That we would have pre-participation exams, we'd have some baseline testing for this patient. That might be things like Y balance test, PQOL inventory, short form 36, to gauge some of the patient rated outcomes, and then risk reduction interventions as well. So this could be working with the coaches to improve practice warm-ups or cool-downs, yoga or foam rolling sessions, or anything that we can find in the literature that can help reduce risk of injury for these patients. Phase 2 is really where we're getting the patient at this point. That's the evaluation standpoint. Getting to know the patient, that really comes down to filling those aspects of the disablement model, right? Understanding what are their limitations, what are the things that we're seeing from an anatomy standpoint, from a functional standpoint, the environmental and personal factors, and really getting to know who our patient is. Identifying the patient goals. With this patient, those goals were returning to play, reducing pain, and improving their athletic performance so they could play more. It's important to know that just because those are the goals for this patient doesn't mean that's always the goals for every patient that participates in sports. So it's important to identify and actually discuss those with the patient. Identify the pain generator. We decided that the iliopsoas was the pain generator. Pain with contraction of the muscle, pain with lengthening of the muscle. We decided that this muscle was stuck in sort of a pain spasm cycle. And so we're going to see muscle shortening. We're going to see tightening or constricting of the posterior hip capsule, some muscle weakness, faulty movement patterns, or some of those associated impairments that we're going to see with that. So we wanted to educate the patient about their condition, about the options, about the treatment, kind of our timeline. And in doing that, we can discuss a patient plan of care and making sure that the patient is actually involved in that development. That brings us to phase 3, which is our intervention or our treatment phase. And we want to make sure we're matching interventions to the patient goals. An example of that, in this case, we see iliopsoas shortening and pain as well. And so an appropriate intervention for that may be some muscle energy technique to try and break that pain spasm cycle, right? The patient's goal is to reduce pain. And so not only might this affect some of the limitations we see as far as the iliopsoas shortening, but it also may help us meet the patient's goal of reducing pain as well. Again, be intentional about your intervention selections. Make sure they match what you're trying to do. So if we want to increase hip internal rotation, we may perform some posterior joint mobs to the hip to meet that goal. If we want to improve the dynamic knee valgus that we're seeing in the patient, we can do some banded side steps to strengthen the glute med. Again, be intentional about the interventions you're selecting, and then use outcomes. So we can assess progress through manual muscle testing, through our Y balance again, some of our patient-rated outcomes we mentioned earlier, and measure these throughout to guide when we're progressing to the next steps of treatment, and whether we're meeting the goals that we want to meet. And then lastly, throughout this whole process, give the patient options. An example of that is I may give a patient 3 different hip strengthening exercises. Maybe they can do banded side steps, they can do some monster walks, they could do clams, they could do lateral leg raises, whatever. And I give them those options, and I'll let the patient choose so that the patient has some influence and some say in their treatment as well. Lastly, phase 4, we want to make sure that the patient's ultimate goals are decided by the patient and that they're being met. So in this case, those ultimate goals were returning in sport, playing college basketball. And we want to make sure that those are the goals that we're setting for discharge, and that we're meeting those goals as well. Using some outcomes such as single leg hop, wide balance score to kind of guide and guide our decision making, along with our own experience, our own medical knowledge, what we know about the anatomy, what we know about how these tissues improve, and then making sure education is a huge part of that as well. And that's educating the patient that as soon as they're done with this phase, they're going to go back to that pre-injury phase, but that these things and these interventions can't just go away, that we have to continue these lifelong actions at reducing the risk of injury. So that is a quick run through and kind of how a case can apply to my clinical philosophy. And you can apply this philosophy to any injury. I haven't seen any kind of injury yet that I don't believe that this can't fit into. In addition, this philosophy can fit into multiple clinical practices, different settings, and even amongst some different healthcare providers. So it does a great job of both creating a patient-centered care model and also an evidence-based model in the treatment. So thank you very much. I hope this was informative and that this clinical practice can be useful in your own applications.